Okay, everybody, it's about a minute past the hour. Folks are still joining, but I think we might as well get started. So good afternoon and good evening. My name is Sarah DeFeo, and I am the Vice President of Scientific Affairs and Programs here at Ovarian Cancer Research Alliance. And I want to thank you all for joining us today as we hear from Dr. Beth Popp about ways palliative care can help you live better with ovarian cancer. So just a little bit of background about our organization. Ovarian Cancer Research Alliance is the largest global organization dedicated to fighting ovarian cancer. We advance research to prevent, treat, and defeat ovarian cancer. We support women and their families before, during, and beyond diagnosis, and we work with all levels of government to ensure ovarian cancer is a priority. Before I get started, just a brief housekeeping note to go through. Listeners will be in a listen-only mode throughout the presentation. We should have some time for questions afterwards, so if you think of a question as you're listening, you can type it into the Q&A box that you can see on the right-hand side of your screen. There's no need to wait until the presentation is over to submit your question. You can just type them in as we go along and as you think of them. And because I know some of you are wondering, yes, this webinar is being recorded and will be on the OCRA website soon, probably tomorrow. Okay, so now about our presenter, Dr. Beth Popp. Dr. Popp is Associate Professor in the Brookdale Department of Geriatrics and Palliative Medicine at the Icahn School of Medicine at Mount Sinai in New York City. She has dedicated her career to improving care and quality of life for cancer patients. Dr. Popp has served as a clinician educator and provided leadership to develop palliative care services at 3 medical centers in the New York area over a career that has already spanned more than 2 decades. She's been on the faculties of the Medical School of SUNY Health Science Center at Brooklyn, New York Medical College, and the Albert Einstein College of Medicine, in addition to Mount Sinai. Her clinical work is focused on management of pain and other symptoms in patients with cancer, communication skills for clinicians, customizing treatment plans to incorporate the unique values of patients, biomedical ethics issues in palliative care, and palliative care needs of the developmentally disabled adult. Dr. Popp participates in public awareness activities about palliative care on behalf of the Center to Advance Palliative Care and getpalliativecare.org, which is a great website. It's CAPC's online resource for patients and families all about palliative care. The website focuses solely on providing information about palliative care from the point of diagnosis. Okay, so let's get down to it. Dr. Popp, I will pass the ball to you, and you can get started. I can take you off mute.
Okay, I hope everybody can hear me now.
Yep.
Great. It's really a pleasure to be with all of you this afternoon or this evening, depending on where in the country you are. And one of the nice things about this time of year is that it's daylight even here on the easternmost part of the audience. It's a pleasure.
That's right.
So let's talk a little bit, and I just want to thank you, Sarah, for your help organizing this, and for OCRA and getpalliativecare.org for the opportunity to have this hour to spend with folks who have dialed into the webinar and are interested in learning about how palliative care can help them or someone they care about who is living with ovarian cancer in that. So what we'll do today is first define and clarify what palliative care is and who can benefit from it. We will talk about how palliative care enhances the care of women with ovarian cancer. We'll talk about some of the most common patient and family member questions that come up in these conversations. And then if I manage the time well, we will have some opportunity to get some questions from you who have been listening to the webinar. So let's start with that definitional question. What is palliative care? Palliative care is specialized medical care for people who are living with a serious illness and it focuses on providing relief from the symptoms and the stress of their illness. The goal of palliative care is to improve the quality of life, both for the patient and her family. The palliative care is provided by a specially trained interdisciplinary team who work together with a patient's other healthcare providers to provide an extra layer of support. And we'll talk in more detail later on in the conversation about the palliative care team and who are those members of the interdisciplinary team. Palliative care is appropriate at any age and at any stage of a serious illness. It can be provided along with disease-directed treatment, or it can be provided alone. And that's one of the first really important take-home points from this conversation, because that's often a misconception that people have, and I want to really stress that point, that palliative care is appropriate at any stage or any age patient who has a serious illness that is causing symptoms and stress and would benefit from that extra layer of support, irrespective of whatever additional treatment specific for their serious illness they're receiving. You know that if you are yourself someone who has ovarian cancer, or are living with someone or a good friend of someone who has had ovarian cancer, that treating the pain and the symptoms and the stress that comes with a cancer diagnosis and its aftermath is every bit as important as treating the cancer itself. We want our oncologists to be focused on treating the cancer, making it go away and hopefully stay away. But in the process of getting there, people who have cancer wind up exhausted, my little cartoon character of fatigue, concerned with losing weight, although sometimes people are also concerned with issues of gaining weight. They may be having serious problems managing nausea or vomiting. They could be having pain, and our brains are running so much into a worry space when we have cancer. And there may be many other things that can be so important and are often not the focus of the oncologist, not necessarily because they don't realize that these things are the case, but their main focus is going to be on treating the cancer, and that's why it can often be helpful to get somebody else involved, like from the palliative care space, who can help with these other things. If somebody has a serious illness like ovarian cancer, we know what we want. We want to treat the disease. We want to make it go away for as long as we can. Ideally, we want to make it go away forever, but if we can't make it go away forever, we want to make it go away and stay away for as long as we can. If we can't make it go away completely, we want to slow it down. And if it's going to be with us for the long term, we want to really be able to go about our business and continue to do the things that matter most to us, even while we are living with this disease in our life. So what we really want is to maintain a good level of function, and what constitutes a good level of function is something that's a very personal matter, and it's a different definition of good for each of us. And we want to have a quality of life that we consider acceptable. And again, the factors and domains that constitute a good quality of life are very personal and speak to our own personal values and goals and sense of what's important, what gives our life meaning, and the things that we want to accomplish. And so the care needs to be tailored to those very personal sense of what constitutes good functioning and good quality of life. Care for cancer is complicated, especially now with many of the new therapies that we have. And for patients with ovarian cancer, it is not uncommon for care to involve a gynecologic oncologist who's a surgeon, Sometimes there's somebody who's different, who's treating with chemotherapy. Sometimes there's radiation involved. Sometimes there are procedures that need to be done by an interventional radiologist. There can be so many different people involved in making sure that we get good care, and sometimes it can be incredibly difficult to coordinate and make sure everybody who's involved in our care is connected. And we want to make sure that we have the support and information we need to help us make really good choices about our care, because sometimes what needs to happen next is not so straightforward. When you have strep throat, you know that you need to take antibiotics, and it's a pretty straightforward medical decision. But so many times in treating an illness like ovarian cancer, the decisions are not simple and straightforward and one size fits all, and we need and can benefit from support to help us make informed decisions that we can look back on and feel like we made good decisions for ourselves when the decisions were a little bit murky and not so clear about what was going to be the right decision. And that is where palliative care can come in. When we think about palliative care, as I said, is really something that is a type of care that's appropriate for anyone with a serious illness. And so as we think about all of you who are listening with a focus on ovarian cancer, let's think about cancer in general. And ASCO, which is the American Society for Clinical Oncology, it's the professional society of oncologists, primarily medical oncologists, so people who use medicines to treat cancer, but also oftentimes other kinds of cancer specialists will belong to ASCO. And they said very strong in their clinical practice guideline just 2 years ago that patients with advanced cancer, whether they are inpatients in the hospital or getting care as an outpatient, should receive dedicated palliative care services early in the course of their disease, concurrent with active treatment. So at the same time that they are working to make this cancer go away or get as small as we can make it, that should not, those efforts should happen at the same time people are getting palliative care, not one after the other. Referring patients to interdisciplinary palliative care teams is optimal, and services may complement existing programs. Providers can refer caregivers of patients with early or advanced cancer to palliative care services because, as I said, we all know that a cancer illness doesn't just affect the person who has the cancer, who has the tumor in her body. It really affects their whole family, and caregivers and family members can often be the ones who need that extra layer of support in addition to the patient. When we think about what people out in the world know about palliative care, and that's a question that was asked by CAPC, the Center to Advance Palliative Care, the American Cancer Society, and their Cancer Action Network, which is a group that advocates for improvements in cancer care policies. About 8 years ago, when they surveyed adults, some adults didn't know whether they knew anything about palliative care or not, but certainly the majority of adults were not at all knowledgeable and recognized that they were not at all knowledgeable about palliative care. There were about 14% who were somewhat knowledgeable about palliative care, but really only 5% were very knowledgeable and 3% were considered themselves knowledgeable. So really not even 10% of the population really felt like they were knowledgeable about palliative care was. So when we asked this group of people who didn't know what palliative care was, when we told them that this was an extra layer of support that's provided to patients to help address the symptoms and to alleviate some of the stressors that come with having a serious illness, it was like mom and apple pie. 92% wanted palliative care for themselves or their family. Similarly, 92% thought that patients should have access to palliative care throughout the country, and 95% said patient and family education about palliative care as a part of treatment was something that was really important. They thought it was really unfortunate that so many people who are dealing with a serious illness like ovarian cancer don't know that palliative care is out there. And I think it's really tremendous that all of you have taken an hour of time to learn about palliative care for yourself or someone in your family, and can help get the word out to people who could benefit from this. In ovarian cancer, more specifically than other types of cancer, quality of life is really affected by the symptoms that patients experience. We know that ovarian cancer commonly presents in the later stages of disease. Folks at OCRA and researchers around the world are working to help us be better at diagnosing ovarian cancer earlier. But the way things are right now in 2019 is that the majority of patients present in the later stages of disease, and there's a heavy symptom burden that has traditionally resulted from both advanced disease as well as the treatments that we have to try and improve the cancer status. Early integration of palliative care and newer disease-directed therapies in collaboration with palliative care for ovarian cancer patients can really lead to improved outcomes and a greater quality of life throughout the time, from the time of diagnosis, throughout the time that patients have cancer and their survivorship period. So how do palliative care teams work with patients and their families? Palliative care teams work with you to find the right combinations of medicines to control symptoms and treatment side effects that range from bothersome to absolutely debilitating. The palliative care team can also help the patient and her family adjust to the presence of this disease in their lives. They take the time that's needed to help you match your goals with your treatment options and make sure that treatment options and your goals stay in alignment throughout the course of an illness. The palliative care team can help you plan for your future medical care needs if that's something that you want to begin to plan for. And they can help you with communicating your goals to other healthcare team members so your goals are always a part of important medical decisions. Palliative care teams can provide psychological and spiritual support and help you with accessing community resources that can help you with dealing with your cancer. So let's talk for a minute about some of the commonly encountered symptoms that we see in women who have ovarian cancer. From my perspective as a palliative care physician who also was trained as a medical oncologist and has really spent my career clinically taking care of patients with all kinds of cancer. Where I work now in Mount Sinai, we have a large women's health program, and so we see lots of patients who have ovarian cancer. Pain is a real problem for many of these patients, and I think the nature of how ovarian cancer presents can make understanding pain a very challenging prospect for many of these women. Ovarian cancer, as many of you know or have experienced, can often present with some somewhat vague abdominal pain symptoms, bloating, changes in bowel habits, and sometimes people, when they wonder whether they should investigate these pains or is this part of a longer history of some abdominal distress issues, often issues with changes in bowel habits, and the pains can be sometimes difficult to localize. And so sometimes those, the nature of those pains can contribute to how long it takes for someone to find out that the reason behind all this pain was ovarian cancer. And then once they find that out, it can really affect their thinking about any continued pain that they have. During the time where they're continuing to get diagnostic tests and get ready to start treatment, to have surgery, or at any time in the future going forward. Addressing pain is really essential for patients to have the best outcome from treatment. Palliative care specialists spend a significant part of their training focusing on treating pain. And we treat pain using a variety of different types of medicines and different types of approaches, not only medicines. Opioids, which are medicines in the morphine family, have been and continue to be the mainstay medicine when we treat pain that comes from cancer. There is increased use of other kinds of medicines that are not part of the opioid family as we try and treat pain. Sometimes the combination of a non-opioid medicine together with an opioid medicine will be synergistic and give us a better response than we would have expected from either medicine by itself. Sometimes people have difficulty with tolerating some of the opioids because some of the side effects that they can cause, and so we can sometimes use non-opioid medicines to help patients get good pain relief with a lower dose of opioids. I think of that as kind of like hamburger helper. It's something that helps that small amount of opioid go further and be more effective, just like that hamburger helper makes the small amount of meat feed a whole family. And we are increasingly using methods that are not related to medicines that we need to take, or even medicines that we need to apply to through our skin, or what we call topically, using other kinds of methods, whether it's bracing or electrical stimulation or physical therapy techniques, heat, cold, relaxation techniques, ways that we can really harness the power of our minds to help us cope and remain functional despite the fact that we have real pain that's coming from real cancer. And those things are not necessarily used instead of medicine, but again, as an adjunct to medicine to help them be the most effective combination and the least problems in terms of side effects from medicine. Pain often changes during a long course of an illness, and it will sometimes get better and sometimes get worse and sometimes get better again. And palliative care specialists are able to check in throughout that roller coaster, hilly ride that comes through the course of a long illness, so that the treatments are adjusted to match changing symptoms. When pain is better, making sure people are using the smallest amount of medicines that are possible to keep their pain well controlled so they can do the things that are important to them. And if the pain is getting worse, adjusting those medicines to continue to keep it in control. The role of opioids in treating cancer pain is shifting. As I said a few minutes ago, opioids have been and continue to be the mainstay type of medicine when we're treating pain due to cancer. And there is an extensive research base on how we can use opioids safely and effectively in patients who have pain that is stemming from cancer. We also, as we get better about the ways that we treat cancer, we have more and more patients who are longer-term cancer survivors, and many of them are long-term survivors without any disease and without significant risk of their disease coming back. And if patients have pain in those situations, there is a trend towards shifting away from opioids. We have other ways that we focus on treating pain because then people become more like other kinds of patients who have pain that is not like cancer used to be when survivorship was very short. And some of the very long-term effects of opioid use can be problematic, and we don't want to create a new problem for a patient who has successfully gotten themselves through the problem of their serious illness. If a patient or for family members have concerns about how pain is being treated, particularly about whether or not opioids are being used correctly by the patient and whether or not the patient is using them in a way that's both safe and effective, a palliative care specialist, because we spend so much of our training focusing on pain as a symptom, can really be a valuable resource for a second opinion, even if they don't need to assume responsibility for all of the care related to pain from cancer. Peripheral neuropathy is a specific kind of pain, and neuropathy in general is the medical term for a pain that results from nerves that are either being irritated or being stimulated when they're not continuing to have some damage to them. Peripheral neuropathy is often described by patients as feeling like pins and needles are being stuck in the soles of their feet or in their fingertips. Some people will describe a sense that their fingers are falling asleep, like your foot falls asleep sometime, depending on the position that you are sitting or laying in. And there are a couple chemotherapy drugs that are used commonly in treating ovarian cancer with a lot of success, but which have, unfortunately, the side effect of peripheral neuropathy. And we have not yet, among our many advances, figured out a way to have equally successful treatments that don't sometimes bring with them peripheral neuropathy, or a way to prevent or completely resolve peripheral neuropathy in 100% of patients. I long for the day when we can do that. Peripheral neuropathy from these chemotherapy drugs may go away slowly after the chemotherapy is completed. There are a subset of patients who will have the peripheral neuropathy pain continue even after chemotherapy is completed. And I just want to go back to this notion of it may go away slowly. When I talk about slowly here, I'm talking about months to years before it completely goes away, even in the patients who have complete resolution. There are some medications which have been used and studied to help the pain from peripheral neuropathy be diminished, to be less intense, and to really be much more manageable for patients. The best quality data actually seems to be for a drug called duloxetine. Duloxetine came on the market as an antidepressant medication. The brand name of the original form is Cymbalta. It's out in generic forms now. And while this came on the market as an antidepressant, we have actually found that it can be quite helpful for some kinds of peripheral neuropathy, including the peripheral neuropathy that comes from these chemotherapy drugs. And one of the things that you will see if you get care from a palliative care physician is that we often are taking advantage of side effects of medications which came on the market for other purposes, and they're not always, the makers of those medicines do not always go back to the FDA, the Food and Drug Administration, to get new indications for the medicines, but we have a strong research evidence base about how they can be used safely and effectively to treat some of these symptoms, and we are usually able to get Medicare and Medicaid and private payers to agree to cover the cost of these medicines for these uses. We just sometimes have to provide them with the evidence base, and so that is one of the challenges that we face, is that sometimes there can be a little bit of a delay getting approval for these medicines, and that's something that many of you have experienced, getting approval for your cancer treatments as well. There are other kinds of neuropathic pain. Neuropathic pain can happen very commonly in diabetes, and some of the medicines that are used to treat these other kinds of neuropathic pain, like diabetic neuropathy, can also be used for chemotherapy-associated peripheral neuropathy. Probably one of the most common questions that I get every day when I am in the office seeing patients, as well as when I'm dealing with residents or nurse practitioners or fellows, other young physicians who are still in the learning phase of their professional development, is what about CBD and what about marijuana? We hear so much, both in the medical literature, but even more so in the press and in the media, about CBD preparation. CBD stands for cannabidiol, and CBD is one of the two primary chemicals that are in marijuana. The other goes by the abbreviation THC, which is tetrahydrodiol, and those two chemicals are thought to be responsible for the majority of the effects of marijuana. While there is a lot in the medical literature about CBD and marijuana, a lot of it is about what our patients are doing, especially our patients who live in states where marijuana has become available, either medical marijuana or recreational marijuana. New York State, where I practice, has medical but not recreational marijuana as of May 22nd, 2019, today. But this is something that's really changing rapidly in many states around the country. And the way, from a policy standpoint, the way research is regulated and these substances are regulated both at the federal level and the state level is different, and it results in it being incredibly difficult for researchers to do the kind of high-quality research studies about the role, safety, effectiveness, and right clinical situations where patients might benefit from CBD or THC in purified forms or in the form of marijuana is very, very, very difficult. And so while it's a topic that is on a lot of people's minds, the research base is very of high-quality research, the kind of high-quality research that you have been using and your care teams have been using to guide your cancer treatment is not available with regard to CBD and marijuana use for peripheral neuropathy or really any other kinds of pain. Other symptoms that can be incredibly bothersome, and some of these are things that we don't think about as being such serious symptoms like pain, but can really become very debilitating and overwhelming, are things like insomnia. And insomnia and sleep disturbance is often tied up with issues with mood, with pain, or with medications that people are taking. Some of the medicines that may be needed while you're going through treatment can be very stimulating or disrupt the sleep cycle. Some of them can be sedating at times and throw off so that you're sleepy during the day and then you're not sleeping at night. In this day where we spend so much time with screens, and if people are not feeling well and they're spending more time sort of being sedentary at home, wanting some quiet activities, they may spend more time with screens, streaming videos, using tablets or smartphones to text or use video chatting services to stay in touch with people who are important to them and they may not feel up to going out to see. Those screen lightings can, which is referred to as blue light, can have a significant effect on sleep disturbance, and people can help address this contributor to sleep disturbance and insomnia by either apps or features on these devices that alter the blue light, especially during the hours before one wants to try and go to sleep. And they're even making now filtered lenses on eyeglasses so that people who wear eyeglasses and use screens a lot can minimize the effect that that has on sleep. Many of the medicines that traditionally have been used to help people who are having problems sleeping lose their potency and can cause dependence. Many people use herbal preparations and supplements that you might get in a health food store to try and address difficulty with sleep. And oftentimes that's okay, but sometimes those herbal preparations or health food store supplements can interact with prescription medicines that your care team is giving you. So it's really important, if you're doing that, to make sure that everybody who is prescribing medicine knows about any herbal preparations or health food store supplements that you're buying. And also being attentive to caffeine intake and the time of day that, if we're still having some caffeine, the time of day that we have it. Fatigue is sort of one of the counterparts to insomnia. Oftentimes, people think that their fatigue is due to poor sleep. Fatigue is really a kind of tiredness that is not the result of not getting enough sleep. It's really a kind of lack of energy that doesn't have to do with how much somebody's exerted themselves already or how much they're sleeping. And it can be challenging, and sometimes that's where a palliative care specialist can come into being very useful and helpful to the patient, their family, and the other members of the treatment team. Excuse me, is to help tell whether the patient's report of tiredness is fatigue or is part of the constellation of symptoms that we'll see when somebody has depression, especially if some depressions present in a somewhat atypical or unusual fashion, or delirium, some psychomotor slowing, which is where people just sort of move in slow motion. And they can interpret that as fatigue because it just seems like it takes so much more effort to move at a usual pace. Managing expectations and teasing out and helping people focus on the best ways to use limited energy can be really important, and the right role for things like exercise, mild activity, or yoga can be helpful in those situations. There are not specific drug recommendations to treat fatigue that we've been able to identify from research studies. Sometimes we will try using stimulants or increased caffeine in the diet. Sometimes we'll use medicine like steroids. Those are medicines like prednisone or Decadron or dexamethasone. American ginseng has been studied. That's something that you could get in a health food store, but it does react with many of the medicines that are used as blood thinners. And so it's really important to recognize that that's one of those cases where a natural health food supplement may be helpful for a symptom, but needs to be thought about in the context of what other medicines are being given and what the overall medical situation is. And I think these are the kinds of symptoms that you often will feel like you're a little reluctant to bother the doctor with, or even the nurse practitioner or nurse from your cancer care team, or you can sometimes just think, oh, well, of course I'm tired. I have cancer. Like, isn't that how everybody with cancer feels? And one of the things that the palliative care team can be helpful about is by taking a detailed history and by their experience with working with many patients who have had these kinds of symptoms in the setting of a variety of different serious illnesses and looking at it from a broad range of perspectives, not simply as, is there a medicine we can give to make this better? We can often be helpful in helping you understand, is this something that you can expect to be going on? Is this something that we can make a little bit better? Is this something we can make a lot better? Is the treatment that we could offer to help it be a little bit or a lot better something that's worthwhile for you in terms of how important it is for you? Depression and anxiety, the most common mood issues that we see in patients who have cancer. When we see who's being referred to palliative care, are really important. And the goal here is not necessarily to make it all those feelings go away, because there are times when feeling sad or worried is normal and needs to be acknowledged and validated. And sometimes we need to feel those things because they're appropriate for what's going on with our health. The fact that finding out you have cancer is really a life-changing event. And having cancer does change your life, and the need for support to get through all of those changes is huge. And we are really fortunate in this day and age that there are so many organizations. OCRA provides support. There are lots of organizations in almost every community that provide support. And even though I talked about avoiding screens a few minutes ago for people who are in more remote areas or a medically underserved area or an area that may have a less well-developed infrastructure for some of these supports, there are things going on online, not just more things like this webinar, which is more my providing all of you with information, although hopefully we are going to have a few minutes for questions at the end, but some even online support groups where people who are experiencing cancer provide support to one another. And the role for medication when we think about depression and anxiety is really for those times when mood interferes with the ability to enjoy life and function in your important roles. It's not about feeling sad when you got bad news or worried when you're going to have a test that's going to tell you whether this newest treatment is working or not. But when that sadness or that worry is so pervasive and so intruding into your thoughts that you can't put it on the back burner or put it on hold so that you can enjoy the things that are usually enjoyable in life, or you can't put it aside in order to function in the ways that are important to you in your life, whether that's your social relationships, your relationships in your home, with your friends, with loved ones, as a caregiver, as a care recipient. And when it's really interfering like that, that's when medication may be helpful. We, in the past, have used a group of medicine called Benzodiazepines to treat anxiety, but we have really a lot of newer medicines that provide a better balance of effectiveness and side effects and are often safer in conjunction with other medicines that people may need to take, either related to their cancer treatment control medicines. People will often say, well, I just feel like I need a Valium, which was a medicine in the benzodiazepine family that was commonly used in the past as kind of a tranquilizer or an anti-anxiety medicine. And we really have a lot of newer, more effective medicines that are more helpful and mix better with other things that you may need to be taking. So don't be surprised if you go through a period of time where you might need some medicines to help you keep mood problems from getting in the way of you enjoying your life, if the medicines that you are recommended are some of these newer anti-anxiety or antidepressant medicines. Sometimes we get really lucky, and the medicines that we could use to treat mood symptoms also help some of the other symptoms that people are having, and we get 2 symptoms improved with only 1 extra pill that needs to be taken during the day, or 1 extra medicine. And we're always happy because the fewer medicines people need to take, the less we have to worry about side effects. And 2 examples of that are an antidepressant called venlafaxine, which can also be helpful for hot flashes, and because surgery that's needed for ovarian cancer often involves removing the ovaries, and younger women who may not have gone through menopause yet, they can wind up with hot flashes. Many people who get diagnosed with ovarian cancer have already gone through menopause, so they may be spared hot flashes as a symptom after their surgery. And duloxetine is an antidepressant I mentioned before that we have really good evidence for its use in neuropathy or neuropathic pain. And so if somebody needs a medicine for anxiety and depression and they happen to have neuropathy, that may make us lean more towards using duloxetine, even though that's not always the first antidepressant that we might choose to use. There are some drug interactions with some of these antidepressants, particularly the groups of antidepressants that are known as SSRIs, selective serotonin reuptake inhibitors, or SNRIs, which is serotonin norepinephrine reuptake inhibitors. Weight loss and weight gain can be really significant issues and affect weight loss. Usually results from loss of appetite or nausea and vomiting. And people can also sometimes have weight gain, and that can really affect self-image. And weight gain can also impact recurrent risk for some kinds of cancers or other health problems that can come up and we're not immune to, even if we had ovarian cancer and have gone into remission from it. THC, which is the other active ingredient that we know about from marijuana, can stimulate the appetite, but THC is the part of marijuana that causes the most side effects with mood and thinking, and so that is not always effective use, because even if it just sometimes the improvement in appetite can come at too great of a cost by negatively affecting people's ability to think clearly or their moods. Body image and body changes are a very significant issue, and this is one of those places where psychosocial support rather than medication can be an important part of the palliative care team's work. Having cancer and going through cancer treatment results in changes in our appearance. Oftentimes we have surgeries and scars where we didn't used to have them. It can change sensations that we feel in our body, whether it's neuropathy and numb fingers or feet, or changes in sensitivity in our body. We can sometimes become sort of overly attentive to every little twinge or thing that we feel, particularly during periods of time when cancer that's at risk for coming back is inactive, because we can be worried that everything we feel that might be not so normal is a sign that the cancer might be back. and we can really struggle sometimes with how much to pay attention to those and how much to ignore them, and striking the right balance of really doing a good job taking care of our own health and trying to ensure that we have the best outcome and that we're, quote, good patients. And it can really shake our ability to sort of trust our intuition about what's normal and what's not normal and what's significant and what's no big deal. And the last, and probably one of the most sensitive issues that can be really challenging for patients and their loved ones to bring up, is how all of this affects sexual issues. Your body changes, your hormone levels change. Mood is a huge factor in women's interest or receptiveness to sexual activity. Fatigue is, the classic joke, has rooted in some reality, but when you're really exhausted, you may not feel like you have the energy to want to engage in sexual activity. And this is something that we do because it's pleasant and pleasurable. And if you're having pain, especially pain that might be made worse when being intimate with your partner, then that takes away a lot from the pleasure. And some of this is hormonally related, and there are some ways to kind of mediate it. And this is something, even as much as palliative care specialists have a lot of training in dealing with some of these sensitive issues, that can be beyond the skill set of many palliative care teams. And the way that they can be the most helpful is just by being receptive to understanding that this is an issue for you, and helping you get a referral to somebody who's a specialist who can really offer expertise in addressing sexual issues for patients and their partners who have medical illnesses. There's a really broad range of the kinds of symptoms that we address, and I'm going to go to a couple of the frequently asked questions now, and then we'll have a couple minutes left for your questions if they weren't anticipated by the FAQs here. So who is palliative care for? Palliative care is really for anybody who feels like they need better relief from the pain and the symptoms and the stress of a serious illness that's affecting them. It's for patients and families who want the best quality of life they can have while they're living with a serious illness. People will ask, is it time for palliative care now? And the right time for palliative care is based on need. It's based on, do you feel like you need more relief from the pain and the symptoms and the stress? Doesn't have anything to do with where you are along the route of your illness. You have this sort of map from diagnosis to cure, or diagnosis to living with illness for the rest of your life, and it doesn't matter where you are along that road or that trajectory. If you feel like you need more relief and that these symptoms and stressors are interfering with your life in a significant way, then palliative care is right now. And it doesn't matter how old you are. You can be young, you can be old. It doesn't matter whether you have early stage disease. It doesn't matter whether you have late stage disease. Doesn't matter whether people are telling you to expect a really good outcome from your treatment, or if people are saying that things may not go as well as you might hope. And it doesn't matter whether you're getting any disease-directed treatment or not. Any time, any age, any stage, if the symptoms and pains and stressors are significant as you think of what's significant, then palliative care is appropriate. What's the impact of palliative care? Well, it can do a lot of things that really you want. You can have better relief of pain and symptoms. I'm going to skip over this really exciting one, which is about longevity. You can have better family support. Many patients who are receiving palliative care, research has shown us, will sometimes go to the hospital less often, go to the emergency department less often, If they do have to be hospitalized, sometimes the duration of their hospitalization can be shorter, and it can reduce unnecessary and often unpleasant tests or procedures that you might go to, that you might otherwise get. Patients may live longer if they're receiving palliative care. We don't know that this applies to every type of cancer or every type of serious illness. There was some very exciting research that came out of the Dana-Farber Cancer Institute in Boston a number of years ago. It was front page of all the major national newspapers and the lead article in the New York Times, that patients who received palliative care early on simply because they were diagnosed with lung cancer that was moderately advanced, stage 3 or stage 4, versus waiting until patients had symptoms and got referred by their oncologist. The patients who got palliative care early just because of the diagnosis that they had lived longer than patients who didn't. And that was really exciting. We are continuing in our field to have more research about what components of the palliative care those patients received contributed to their longevity and how those findings might apply to people who have other kinds of cancers. But the notion that we could help people feel better and live longer was really exciting. Who provides palliative care? The palliative care team is a group of specialists, including specially trained doctors, nurses, and others, and those other people are social workers, physical therapists, occupational therapists. Sometimes it includes speech therapists or dietitians, creative arts therapists like music therapists or art therapists, when either that patient is a child or there are young children in the family. Many palliative care teams will include or access services of a child life specialist, which is a healthcare professional who specializes in children either dealing with, primarily children who are seriously ill themselves, but they will often collaborate with a palliative care team to help children who are living with an ill parent or in a multi-generational household with an ill grandparent. The palliative care team works together with your cancer care team in coordination, and the palliative care services can be provided in a variety of settings. They started out often in the hospital setting, but there are now palliative care services that are provided in rehab facilities, outpatient clinics, cancer centers, and even home-based services where the palliative care team members come to you. Patients can initiate discussions about palliative care, and that is actually at this point how most people get a referral for palliative care. They ask their doctor about it. You don't have to wait until your doctor brings it up or suggests it. Palliative care teams are specialists, so the primary care or the cancer care team needs to bring them in and request a consult. And sometimes there may be a need, depending on your insurance coverage, to get a referral for that care to be in your network. But the palliative care teams are there to work in partnership with your cancer care team and your primary care providers so that everything is done in coordination with your other care. How and when can you ask for a palliative care referral? Again, if you're really feeling like you are significantly affected or suffering from pain or other kinds of symptoms or the stress of this cancer or cancer treatment, just ask your doctor for a palliative care referral. Tell them that you think you could benefit from an extra layer of support. The patient, the family, or the doctor can go on getpalliativecare.org, which, as Sarah mentioned at the beginning of the webinar, is the patient and family education website that was created by CAPC, by the Center to Advance Palliative Care, and it's got a provider directory. It has a lot of other really helpful resources. It's got educational information. It has definitions. It's got a brief assessment so you can try and understand if palliative care is right for you. It has information about how to get palliative care, tips on how to talk to your doctor, has some really wonderful real stories about people who are living with ovarian cancer and other kinds of serious illnesses through podcasts that are available free of charge. They offer webinars and educational activities similar to this webinar on their website for managing specific symptoms and living with different kinds of serious illness. They do have this provider directory that would help you find somebody in your state, and now there are community-based listings, so not just statewide for some of the larger geographical or more spread out areas, and a really helpful downloadable handout about what you should know. So what are the key takeaways before we take a couple minutes to get your questions? We're living longer than ever with ovarian cancer and other serious illnesses. Patients who are in those situations often have symptoms that need to be addressed by specialists, and they're not always addressed by their oncologist or their primary care doctor, and that's where palliative care teams can help. They can help make sure that the cancer and the symptoms are treated. They can improve the outcome for patients and their family, and the patients and their family members can ask for palliative care to be included in their care. My little asterisk on this last slide about patients is that increasingly, as we have better and better outcomes, we have patients who need palliative care services during treatment. Their cancer is put into remission for long term. They are cured. And those cancer survivors sometimes experience longer term effects that are related either to the cancer itself or to the cancer treatment that was successful. And in some places, cancer survivors who have some of these long-term effects are also being cared for to address their symptoms by palliative care teams. Palliative care teams are a limited resource in most communities and most health systems, so that is not always the case. Sometimes the sense is that patients who are receiving disease-directed therapy have a greater need, and so those limited palliative care resources are reserved for the patients who are undergoing cancer treatment, and they will develop other means and services to address survivorship issues. I just want to put that out there that there are some places where cancer survivors in remission are also being cared for by palliative care teams. So if you want to get more information, go to getpalliativecare.org and you can learn more. And I really appreciate everybody's attention, and I am happy to take some questions if we have a minute or two left for them.
Great. Dr. Popp, thank you so much. That was terrific, very comprehensive. You answered a lot of the questions that came in just in the course of your talks. It was great. We are out of time. It's after the hour, but just in terms of maybe one or two questions, I do see we're losing people here. A lot of questions came in about how to integrate palliative care into the care team with their existing oncologist. So one person asked, shouldn't I expect my existing doctors to be taking care of this already? Should they already be aware of this? And, why bring yet another doctor into this already crowded medical team? And what to do if your doctor doesn't get palliative care and seems to be resistant to referring. So that's sort of a big question, multi-part question, but about how to integrate this new care into the existing care team.
Sure. So, the relationships between palliative care teams and cancer care teams vary a lot, and the palliative care skills of cancer care teams vary a lot. There are some places where the cancer care team is really expert and very committed to providing a lot of palliative care themselves, and they may not refer patients to palliative care unless a particular situation is very challenging and the usual things that a palliative care doctor would try haven't worked. I think it's really analogous if you think about somebody who's got a really difficult heart condition with an unusual heart rhythm. There are some primary care doctors who can manage some heart issues, and there are other times where those general skills will be exhausted by a really difficult case, and they may call in a cardiologist. And sometimes they'll just ask for a little advice but continue to manage the situation, and that's exactly what we do. Sometimes I will just see a patient for a second opinion or to offer outline a management plan, but the oncologist or the primary care doctor will really carry that plan out and check in with me from time to time. And there are other times where the oncologist or the primary care doctor says, I don't know how to do this well, but I know it's really important to my patient, and I think my patient deserves the best care possible. So even though it can be challenging to have another clinician in the mix, I think it's worth it in that case, and so I want to have you see the specialist. And then we can work together to figure out what makes sense in terms of the logistics. And it can be difficult to work in an extra doctor when you're having lots of doctor's visits for all your different treatment. We try really hard. My practice is located in a cancer center. We try really hard to have appointments the same day that somebody's coming to see their oncologist or to get treatment, if that's easier for patients. Sometimes the extra visit is easier because each visit is shorter. Sometimes if people have a long trip to get their care, they may want to be there all day and get all their visits out of the way, even though it makes for a long day at the cancer center. So there's a lot of variation. And I think that's the first question you asked. And the second question was about what if your doctor is reluctant? I would feel sad about that for a minute, but I would also just, find out whether you need to get a referral or not in terms of your insurance coverage, but simply tell your doctor, look, I really want to try this. I don't think there's anything to lose. I'm going to ask the palliative care doctor to check in with you. We're not going to do anything that's not going to be in coordination with what's going on or that might jeopardize my cancer treatment, because getting better is what's important to me. I just want to feel as good as I can while I'm getting better. And I would think that that would be a very challenging thing for most caring physicians to turn down. At least I would hope so. But that would be how I would recommend approaching it.
Great, thank you. I think we will end there. It's 10 minutes past the hour. Thank you so much, Dr. Popp. Thank you, everybody, for listening. Lots of great questions came in. Definitely want to refer everybody to www.getpalliativecare.org. As Dr. Popp said, there's a lot of great content on the website, and some of the questions that you're asking will be answered on the site. Also, just a little plug, for those of you who want to hear more about this topic, we are going to have a session on palliative care for ovarian cancer patients at our national conference, which will be in Seattle in July. You can find more information about it on the OCRA website. So that's it. Please take a minute to fill out the survey that will appear on your screen at the end of this webinar. Again, this has been recorded, so you'll be able to listen to the audio and see the slides again. They'll be posted on our website probably tomorrow afternoon. For more information about OCRA, you can always visit our website at www.ocrahope.org. And again, thank you, Dr. Popp, and thank you all for listening, and have a great evening.
Thank you, Sarah.
Thank you.